Hello, my name is William Rigby, and I'm here today to talk to you about B and T cell directed therapy for rheumatoid arthritis that was recently presented at the American College of Rheumatology 2011 meeting. In this schematic, which is well known to many of you, we have T cells, B cells, macrophages, fibroblasts like synoviocytes, and osteoclasts interacting in the pathologic process of rheumatoid arthritis. I show the B cell, I show TNF, IL-6 as established targets in rheumatoid arthritis. Today, we're going to talk about four biologics that are targeting B and T cell activity in this process. There's going to be abatacept, and I'm going to be talking about the IV and sub-Q formulations. Rituximab, which is a chimeric antibody shown in blue. And humanized antibodies, secukinumab and LY2439821, that targets a humanized antibody that targets IL-17A. Specifically, we're going to talk about targeting of IL-17 in this model system, as well as interactions with these novel agents. IL-17 has been a very promising agent in mouse models and has been very interesting in terms of its involvement in causing joint disease and erosion, but also many other inflammatory diseases such as psoriasis, multiple sclerosis, and inflammatory bowel disease. Indeed, it's been implicated in all of these. So what about, in our program overview, what about its targeting in RA, and what's the clinical utility of this? Well, there have been two studies in the last year with two different agents that I'm going to review for you. The first of these was presented in 2010 at the American College of Rheumatology by using an anti-IL-17A antibody called secukinumab. And this was a phase 2B double-blind randomized controlled trial in 237 patients with RA unresponsive to methotrexate. And it was monthly sub-Q or placebo injections every 3 weeks. And the ACR 20 was judged at week 16. And what I show you in the table is the ACR 20 responses, the delta DAS28 change using the CRP, and the ACR 20s at 12 weeks. I showed the ACR 20s at 12 weeks because the other two panels are addressing 16 weeks. What you see is that the placebo response in terms of ACR 20 is 36% at 16 weeks and 22% at 12 weeks. This bump in the placebo response made it very difficult for anybody to see any significant activity. There was not a statistically significant ACR 20 benefit at 12, but not 16 weeks. And this was due to the placebo effect. There was no increased AEs. There was some mild benefit in the DAS28 CRP, but the other thing that's of concern is that these responses are relatively flat, meaning the same dose effect is seen at 75 milligrams sub-Q as 300 milligrams sub-Q. So this was not an entirely promising study at 16 weeks, but at 12 weeks it looked promising, and we await further developments with this agent. Now, another company has made a compound targeting IL-17A and also a monoclonal antibody, LY2439821, and they did two large double-blind randomized controlled trial dose-ranging studies. 260 patients were biologic naive, and 188 were TNF inadequate responders. And I showed the TNF inadequate responder font in red to focus you in the table slide so that we can appreciate these effects relative to each other in these two different groups. The placebo, there was a placebo arm, and the data is shown at 12 weeks. There's dosing of 3, 10, 30, 80, and 180 milligrams. In other words, there is a 60-fold range in antibody dosing. I want to emphasize that there was no major safety signal seen in any arm of either study. And what you want to look at is the ACR 20 response at 12 weeks with this agent. In the study in the biologic naive, it was 35%, remarkably close to what it was in the previous study. And then you saw responses of 45, 43, 70, 51, and 54 as you proceed down, looking at the various dose responses. ACR 50s, again, 9% in the placebo arm at 12 weeks, 18, 29, 30, 26, and 27. Again, a relatively flat dose-response curve. And this is also echoed when you look at the delta DAS28. And this is just thinking about the methotrexate IR, or biologic naive patient population. Now, when you look at the TNF-IR patient populations in the same panel but shown in red, you can see that the placebo responses are lower and that there's a little bit of difference between, but only the higher concentrations of the drug are being used, and there's a slight effect in terms of ACR20 between the placebo and the 80 and 180 milligrams. There's also a slight effect on ACR50s. But interestingly, the delta DAS28 is also increased about 22-fold. So depending on how you look at this, drug shows some activity, but it does not seem to be ideally formulated or applied in this situation. These are not the kind of responses that I think may not be so promising as to promote further development of this agent in rheumatoid arthritis. But the other possibility is they may be encouraged and attempt different strategies. Our next section that we're going to overview is the advent of subcutaneous use of abatacept, and this is the first non-TNF biologic to be developed for subcutaneous use, and it looks very promising. And there were two studies to look at the advent and promise of subcutaneous abatacept. In 2010, they established that the subcutaneous abatacept seemed to maintain responses, seemed to be very tolerated, seemed to be non-immunogenic compared to IV abatacept. And there are two trials that were presented at the ACR this year. One is the ACQUIRE trial, comparing IV versus weekly sub-Q, so monthly IV versus weekly sub-Q, with the sub-Q dose being 125 milligrams per week. And the sub-Q dose got a one-time IV loading dose. The DAS remissions at 6 months were exactly the same. And after 6 months, the patients were switched to all sub-Q, and these DAS responses in both arms went up to 32%. So in long-term extension, this drug seems to be very safe. It seems to maintain the responses that we're seeing with IV, and the sub-Q dosing seems to be equivalent to the IV at 6 months if you load once with the IV. Now, the ACCOMPANY trial looked at IV loading and then weekly sub-Q versus subcutaneous dosing only. And this is in a DMARD and TNF-IR population. It's somewhat mixed. The DAS28s at baseline were pretty high. At month 3, the delta DAS was no different in whether you got the IV load followed by weekly sub-Q versus just weekly sub-Q. And that, moreover, the company is aware of the target steady-state levels of 10 microgram per mil, and they realize that when you monitor this in the sub-Q only population, the target steady-state levels achieved at day 15 without the IV load. In short, the subcutaneous abatacept seems to be an alternative to IV. It seems to be equipotent, and it doesn't even require IV loading. And we'll just have to see what the uptake and use of this agent is, but it certainly is very promising. It may represent the direction for many other of the biologics coming down that are in use and maybe coming down the pipeline. And this is to obviously promote the development of agents and approaches that can be done completely as an outpatient and not necessarily even in a doctor's office or clinic. The third component of our program overview is going to be rituximab and efficacy and safety data. The Sundial trial, I thought, is a very interesting trial in that this was a trial where rituximab was added to patients already on biologics with inadequate response. 176 patients were given rituximab 500 milligrams times 2, and of those 176, 147 were given a second course. They were kept on their abatacept, the 15%, and or TNF antagonist, 85%. And this was a safety study that was mandated by the FDA to the company. And what's interesting is that the 48-week safety data, so this is where most of the patients have had 2 courses, the serious infection rate was 2.7 serious infections per 100 patient years, and 2.2 serious infections per 100 patient years in the 147 that had retreatment. These numbers are very low, and these are as low as has been seen in any study, with much lower as any study with rituximab alone. But interestingly, they are much, much lower than the previous rates of serious infection that were seen with the combinations of etanercept and anakinra, and the combination of etanercept and abatacept, where the numbers were 7.4% and 5.8% serious infection rates at 24 weeks and 1 year. This is really quite striking and really seems to suggest that not all biologics are equivalent in terms of their placement of individuals at risk for infection. Finally, EULAR to moderate good responses were seen in 61.4% of the patients entered in this trial, and this includes the seronegatives patients as well. So in other words, I think if one had a take-home message from this trial, it shows that concurrent biologic use is safe. Not that anybody will ever be doing this, at least not until the data shows clear efficacy and long-term benefit. But that I think the particular application of this is that to individuals that are failing a 1-TNF or abatacept or tocilizumab, is that they can be probably switched to rituximab without a waiting period. In terms of the safety data with rituximab, the long-term all-exposed population now is at 11,000, nearly 12,000 patient years. And I want to direct your attention to the patients that are also on greater than 5 years of therapy. And this is compared to the cohort of placebo patients that were placed on in the early 6 to 12-month trials with rituximab. And the serious infection rates, the SIEs, are shown at the bottom, and they are essentially unchanged. With 9.5 years of follow-up in nearly 3,000 patients and 3,200 patients, there's no increased issues of infection or long-term safety that have arisen. There's no increased malignancy, no increased cardiovascular disease, and this is with now patients having received up to 19 courses. There's now there's no new cases of PML, and there's nearly 170,000 treated patients in RA. Now, the PML question is always interesting, and one group decided to look at the relationship between rituximab and JC viremia, meaning JC virus is the polyoma virus associated with PML. And they looked at a German rheumatic disease cohort treated with rituximab. And they had pre- and post-rituximab samples in 20 patients. 13 of the 20 were negative for JC virus. 5 were positive for JC virus, and 2 were positive and then turned negative. In short, 13 were negative and stayed negative, 5 were positive and stayed positive for viral DNA, and 2 of the patients who had JC viremia detectable before treatment with rituximab turned negative. In the other 64 patients, there was no, in the remaining 44 patients, there was no obvious effect of rituximab on JC viremia. And I think one thing we can conclude is maybe this is not unexpected for an event that seems to be extraordinarily rare, meaning approximately 1 in 30,000. Finally, we're going to talk about efficacy in RA, and I think this is going to point to these 3 trials I'm going to discuss are going to point to the challenges we face in comparative efficacy done by registry approaches. And this will really argue for the head-to-head trials that will hopefully be in our future and provide clarity to these issues. The first trial, first registry set of data came from Corona, and where they looked at how a second TNF performed versus a switch to abatacept after failing 1 TNF. They took all their patients, 546 patients, switched to a second TNF versus 335 patients switched to abatacept. Matching was performed. Their mean CDI was 22 to 23. This is different from what's usually, and they did a weighted mean improvement calculation so that within different centers, variability was dealt with or compensated for. If you look at the CDI at 6 months of follow-up, an anti-TNF agent resulted in a mean improvement of -6 units. And the CDI with TNF and anti-TNF and abatacept was -6.6. The ACR 20s and the percentage of patients getting into DAS, low disease activity, there's no significant difference. Now, a different way of looking at this question is not to think about scoring in the office, but how long does the patient get kept on the drug after failing a TNF antagonist, or getting switched to another TNF antagonist. And the idea is that physicians switch people if they don't do well. And so this is from the Canadian Rheumatoid database, electronic database. And this is just monitoring the duration of patients who, after failing one TNF, stayed on the second agent. And they had 119 patients, and their target was 36 months of follow-up, so significant time of follow-up, meaning 3 years. So this is really a retention study. And if you look at the biologic agent and you look at how long they stayed on these agents, the numbers are shown on the right-hand column, percent that stayed on the switched agent at 36 months. All groups were matched for baseline DAS and CDAI, except the adalimumab group, which seemed to have, just in general, a lower mean DAS and CDAI by about 25 and 33% respectively. Of adalimumab patients, 50% were maintained on adalimumab for 36 months. It was nearly 77% for rituximab, 52% for etanercept, 33.3% for infliximab, and 57% for abatacept. And what you could sort of look at this is say that for reasons that are best known by the physician, but also in a completely unselected way, rituximab therapy seemed to have the most longevity in terms of promoting long-term use and retention by its physicians. Now, finally, the French registry has a large sets of patient numbers getting treated with rituximab and abatacept. And you can see the numbers with the 1,700 patients treated with rituximab and 508 patients treated with abatacept. And this is usually after failing a TNF antagonist or being resistant to TNF antagonist activity or a safety event. And what you see is that the mean change in the delta DAS 28, and the numbers are obviously very comparable. The numbers in EULAR moderate to good responses are very comparable, and the DAS low disease activities are obviously very comparable. There's no significant difference. Now, one point of fact is that the rituximab registry had a higher incidence of cancer, 12 versus 6% in the abatacept, perhaps reflecting the French rheumatology community view of when rituximab is of particular value. The second component is that they had a higher incidence of prior biologic use, and they had a higher baseline DAS. But even within those things, I think you have to look at, we're not doing routinely deciding to use abatacept versus rituximab based on our DAS at the number of prior biologics. We're using rituximab. We're making a decision between rituximab and abatacept and which way can help the patient the most. And I think these three slides point out the confusing approaches or ways of looking at it, this issue. One issue is to look at registry data and or long-term follow-up using measures. The other one is to just look at retention of who stays on the drug and so forth. Now, those are both confounded variables and confounded measures, and of course, we're hoping for more clear-cut data. But that's the best we have. In summary, the take-home points is that anti-IL-17 targeting in RA, at least the target of IL-17A, has some promise, but it does not seem to be particularly strong. I think we have to also clearly welcome the arrival of the first non-TNF sub-Q biologic in abatacept. It's clearly effective and clearly useful. Rituximab provides continued safety benefits along with all the other agents, and the use of rituximab in combination biologic therapy is obviously of great interest to us in terms of the safety profile and possible clinical application in patients that have failed the TNF antagonist. Finally, the registry data are yielding important insights, but I must emphasize that we are not really clear on what those insights are going to be played out. But it certainly appears that in most registry trials, the switch to one agent versus another agent is not showing clear-cut benefit, except when one looks at retention data. And so what I'd like to do is direct you to talk to our program at www.ccfcme.org /15 minutes. And thank you very much. And I look forward to seeing you online again sometime.